Dr. Kahali here. Happy welcome to the city of Joy, sir, and welcome all the panelists, Chair, and TCT Srinivas, Gary, and everybody over there. Can you listen to us?
Yes, we can hear you and see you well. Do you want to introduce the case to us?
So, yeah, sure. So this is a 63-year-old gentleman. Where is the and admitted with severe angina, and the patient has a severe COPD as well. So we took a heart team approach, and the patient is diabetic, uncontrolled diabetes. Patient has severe COPD. Patient is history of hypertension and was admitted with CCS class 3 angina. His ejection fraction is good, and he had a stenting of LED in 2008 in SSKM hospital, and then in 2015 he had a repeat angiogram which showed a moderate lesion in the left main, 40% like that. But when we did the angiogram this time, we found that left main ostium has a very tight 80-90% lesion, and the patient was having severe angina. So we took a heart team approach. We took the opinion of the surgeon, but surgeon told the patient has severe COPD, so better you go for ostial stenting. And his RCA also shows a tight lesion at the origin. So we did a RFR because the patient has COPD. We didn't want to give adenosine, and RFR shows the value 0.97. We have done 2-3 times, and it is 0.97. So just now we are listening the virtues of FFR, OCT, etc. And just now we did the RFR over there in the right side, RCA. Show the RCA, na? Show the RCA. Show the. Yeah. And
I think that's an interesting point, right? You know,
so
if you look angiographically at that lesion, most people would agree that it was tight. Do you have the tracing for the IFR, or?
Yeah.
Can we see the tracing? Or
yeah, we have the tracing. Can you show the tracing, please? Yeah. Can you show the tracing, please? Yeah.
It'd be useful for education.
So this is the RFR. Yeah.
Very good evening.
So the RCA proximal lesion spatially looks to be quite tight, but that is the virtue of FFR, that we did the FFR, and it is irrelevant. It is 0.97, you know.
That's good.
So the value for FFR, RFR is 0.89 instead of 0.8 with FFR, and it was 0.97. So both the times it was high. You can see it, and there is no gradient across the mid RCA lesion as well. So no question of intervening in the RCA. So we have to be content with doing the left main ostium.
We have one comment here.
So we have put a BMW where, because.
Well, one moment, just wanted a quick discussion from the panel. One comment here.
Yeah, very good evening, Dr. Kahali. Here's Dr. Ferenc from Germany. So I was, I think, last year in
Dr.
Kolkata.
Ferenc, how are you?
We
fine. Met in Europe PCR.
Yeah, exactly. Thank you. Thank you.
It's nice when you talked that you will be coming to Hyderabad.
Yeah. Thank you. Really nice to see you again. So the question is.
Thank you, Dr. Ferenc.
So I think the right is very clear. I think it's a clear statement, and it was really good to make IFR for safety reasons. The ostial LAD, ostial left main lesion is clear. There is probably also problem of the aorta ascendens. Did you perform CT scan to see that there's a porcelain aorta? Because we have to put stent which is large, which has good radial forces, you know, which doesn't collapse.
Yeah, that's a good point. There's a calcium on the angio at the ostium of the left main, and I think that's relevant in terms of, but it doesn't look like it would be circumferential, but in terms of expansion and strength, those are obvious concerns. Just real quick for the audience that doesn't do, if you're going to use a tool like IFR or FFR, it needs to be done properly, especially for osteal lesions. You want to make sure you equalize the catheter in the aorta, not after you're already across the lesion, because you have to equalize in the aorta. You have to engage, flush, disengage the guide when you do the readings. And so then if you don't do the readings properly, then you'll get false readings. So I think, especially for osteal lesions, those careful techniques of equalizing in the proper place, flushing, disengaging the guide are important to make sure.
What is really helpful if you take access support wire, first of all, standard access support wire put into the vessel, then you stabilize the guiding catheter, and then you can very easy go outside the catheter with a FFR wire and equalize whatever you do. This is, I think, a small tip for the.
So
that's a great suggestion.
So can you tell how should we proceed? What's the opinion of the panelists?
So I think this very clear, highly significant osteal left main stenosis. So we have to treat. This is very clear. I think we need quite a short stent, but the stent must be placed perfectly. So you need maybe a 1 millimeter stent must be outside into the aorta to be sure you don't let some gap.
But there's also disease, as you mentioned, distal. Like there's also disease in the distal left main proximal LAD. And we had a live case in the first session talking about left main intervention. There's a lot of discussion about whether imaging prior to stenting is mandatory to understand what you're doing. So imaging the osteal LAD, the distal left main, and the osteal left main may add value here.
Yeah, after opening the left main, because the left main is so tight. So first we want to dilate the left main with a 3-9 balloon, not 3-9, 310 balloon.
Yeah, I think that's. I think that makes sense. It makes sense to avoid ischemic events. So I could remember. I think last year I had similar case, and there was a fibrillation, ventricular fibrillation, so stress.
You got to be careful in these lesions.
So I believe you go with 3.0 non-compliant balloon just to open the ostium.
The calcium there is a marker, so I would probably come back a little bit, right? You can see that calcium nicely there. And we talked in the cranial views are sometimes useful for these as well, LAO-cranial especially, to lay out the ostium.
You go to the cranial view, 30 degrees. This is cranial view, And in all the views, the lesion is not so prominent, but in this view, it's very prominent. So, dakho. So, there is calcium over there.
I think you have to go still. No, it's not bad. Maybe millimeter back. Yeah. We are going to dilate the lesion. This is. Maybe you could go to LAO cranial. LAO cranial will be even better. So this is non-compliant balloon or semi-compliant? I'm not sure.
It's a non-compliant. I think he said it's a 3.0. So you can see the blood pressure came down. So in some of these scenarios, you want to give short breaks. You don't want to be occlusive for a long period of time. If you see the pressure coming down, you want to come down with the balloon quickly. Pressure's down a bit here, so I would probably come down with the balloon, reperfuse. Then in this case, you got to get the guide catheter out and disengage the guide.
Pressure is coming back, okay.
Coming back. So again, got to pay. It's as they're showing here. You got to pay attention to the hemodynamics. If you see the pressure dropping, you know, short inflations, disengage the guide between inflations, allow reperfusion to occur. If the pressure's not recovering, do a shot. Make sure there's not a dissection that's extending down the circ or LAD. But now you see the pressure's recovered nicely with just a short rest.
To be honest, I think we didn't reach enough with 3.0, so probably we have to take even bigger balloon to make one more sufficient predilatation. So I would suggest to go even with minimum 3.5, maybe 4.0 non-compliant balloon. It will be my suggestion. Can you hear us? I think there is no connection.
Can you hear us? Did we lose their voice? I think we lost the audio from the site. Is that right? Srinivas? Yeah. Okay. Well, we can't hear them, but we can at least see what they're doing in the meantime.
That's up because we lose audio. So I personally would go with a larger balloon before I would choose the stent. And now the question is, there is a osteal main problem, but if you see in this projection, complete left main is diseased, and this is exactly the question: should we cover complete? Maybe we could have one more projection to decide. Do we have to involve bifurcation or even not?
And it's important to keep in mind the point you raised earlier is an important one. This is a lesion that may not be in the vessel; it's in the aorta. Right, and the aorta is a different entity, different fibroelastic structure than the coronary arteries. So this is an aortic lesion that you're trying to stent, essentially. So you may get expansion of the balloon, but it may recoil because that's just the properties of the aorta. So you can. There are several approaches, and I think taking a larger balloon just to make sure you can expand is very reasonable. Running the IVUS quickly. So when you do an IVUS here, I would just do a quick pullback or even manual right at the aorta, so you're not creating ischemia for a long period of time, if that's a consideration. Or you can just, do a larger balloon and then just take a stent, fix the aorta, and then fix the lesion, and then IVUS after as well.
I think what is very, once it's clear, OCT doesn't make sense here in this scenario, right?
Yes.
So only quick, fast IVUS will be helpful, but they have probably one bigger balloon.
Yeah, I'm assuming this is a bigger balloon.
Do we have chance to get audio connection?
So again, in this patient, the right coronary is essentially non-dominant. I think it's slip distal.
Slipping,
yeah, slip distal.
So one more option is, or help is, if you take longer balloon in this case.
And hang out in the aorta.
So I would suggest minimum 15 or even 20 and hang to the aorta.
Right.
This will be definitely also some additional information regarding the needed length of the stent.
So it may be worth one more inflation, centering the balloon on the calcium.
Yes.
Since you already have the balloon there.
But I think the lesion starts even before this calcium marker, So the patient is, as we can see, at the moment very stable. That's fine. And maybe the lesion is oval, so maybe they could make fast run with IVUS to see how it looks.
Sir, IVUS is not available today. It's out of order. We have an OCT.
Oh, I see. Okay.
But
IVUS is not working today. There.
Okay.
Yeah,
So,
yeah.
so if you don't have IVUS, that's a very clear suggestion from my side. So you need longer non-compliant balloon. You have to go with a balloon a bit more to the aorta, and then I would go at least with 3.5 or better 4.0 non-compliant balloon.
So we went with a 4 millimeter balloon for 10 at 12 ATM.
It was slipping.
The second one. Oh, audio is disturbing. Yeah. With the second balloon,
we were just commenting that it seemed to have slipped watermelon seated distal, so it maybe did not get the lesion.
Second, we have to keep it in the aorta. Of course.
So you put one wire more?
Yeah, we are putting one wire more, yeah.
This is also an option, yeah.
In this scenario, any cutting balloon research, like even after 3 balloon, the osteal
I would be worried about doing it at the left main ostium. I think the risk of a dissection, potential risk of injury to the aorta, I would be cautious about it. But it's a valid point. Angiosculpt or cutting balloon would be more stable. But I think if you take a longer balloon and hang out in the aorta, you can accomplish what you need to.
This will be the next step, definitely.
What is that? Huh?
Take it in the key, cast for the cuff surgery.
Okay.
So would you like to place wire in the
So
circ?
regarding pen, what size you want to get? So keep it like this.
Okay, no problem. Oh.
So maybe they just place wire in the aorta to have information where's the ostium, you know. Because they are not in. Are they in the circ? I'm not sure.
Where is that wire? Is it in a left atrial branch or is it in the aorta? Aorta. Okay.
Yeah.
But that's actually can serve a purpose as well, because that helps delineate where the ostium is.
Once again, I would go to definitely to LAO cranial. This is the best projection to have a very clear information regarding the left main ostium. LAO 30, cranial maybe 25-30. That will be my personal recommendation.
I think osteal left means the LAO cranial is the best view. In the majority of patients. Obviously there's some patients, this gentleman has bad COPD, whether the heart's rotated or not. Here it's a little bit not, maybe less LAO and more crani will help, because you're overlapping here a bit.
Exactly.
We lost him. I think we lost the audio again.
Less LAO, please, and definitely a bit more cranial. Then
so
it will
do you
be
want
nice.
any more views, sir? Okay. So we are planning to take Giant's expedition 4 into 12.
We cannot really hear you nice.
Can we turn their site's volume up?
Yeah, sir, we want to take a 4 into 12 Giant's expedition. Is it okay? Because dilating with this balloon, scored balloon or flexitome, it's, there may be dissection. So which size stents do you advocate? Can you listen to me, sir?
Unfortunately, we can't hear you well. So.
Yeah.
But Kahali, we are not able to hear you well. That's why they now respond from this side.
Yeah, I am talking, but I think it's not going. I can intermittently listen to you. Sir, I was asking what size tent would you prefer? Because we would like to put the stent, and if required, we'll post dilate.
Yeah, I think you can go ahead with your plan. When we are able to hear better, we'll start communicating. We'll keep discussing with you. As of now, what we understand is you're trying to take a 4 into 10 stent and probably
12, 4
extend
into
the
12
ostium.
expedition, yeah.
Okay?
Yeah, I think that's fine. If you take a 3.5 or 4.0 by 12, I would do 4.0.
Yeah.
Something a little bit longer because you need to hang out about 2 millimeters. You need to be proximal to that calcium.
Did you hear that suggestion, Kahali?
Yeah, he was advocating 4.15.
I think
We have
to
opened
take
it.
too short
But they have opened 4.12
short
already,
stand will be difficult to
It tends to
place.
milk out also
And,
sometimes.
Yeah, it's really problem for dislocation. And
He has taken your advice and
please
changed to
take
4
it
into 15.
longer. It makes your life easier and safer, more safety for the patient.
The other case here, you have to. It's a longish left main, so even a 15 won't cross over the circ. So even if you want to stay short of the circ, it should be fine.
Yeah.
Hang out 2 millimeters.
The length was 14, so we chose to take 4.12.
412, okay.
Measured, yeah, 4.12. So
Yeah, 12 is better because 8 sometimes tends to slip unless left main is very short.
I would never do an 8.
Not very short, sir.
No, 12 is better.
Yeah.
So you have which diameter? 5.0?
So 4 millimeter.
4.0, 12.
Take it up.
And then
so you go to that.
I would go back to your other view and check. And
This
in
time.
left main, you want to get
that view,
orthogonal
sir. We are
views
going
and
to
check
RO,
multiple
yeah.
projections
Yes,
before
sir,
you
yeah.
deploy.
Yeah, we are going to RO, sir.
Yes, sometimes epicaudal projection is also helpful. But definitely to check in 2 different projections is essential.
We have to come back a little, I think.
Yeah, probably caudal view to check distal position and cranial views to check the ostial positions are better.
I think it needs to be a little bit more distal.
Oh, this itself is just short.
I think.
Could you check again from distal view? Caudal.
Yeah.
That's not
Caudal.
not sure.
Caudal view. Go to the caudal one. It's negative করেছো? Negative করেছো? Huh? Dhiman.
I think it needs to be a little bit more distal. I don't know. What do you guys think? It's hard to see here, but.
Sine.
No,
it's not seen.
definitely.
I think it needs to be more distal, no? Yeah.
Maybe RAO caudal sometimes.
Yeah.
RO caudal.
RO caudal.
So the hemodynamics are good. These are the times you want to take multiple views and make sure you're comfortable with the position, right? The hemodynamics are good. You're not rushed. Take RAO caudal, AP cranial, all the different views to reassure yourself.
No, you have to come back.
I would get
a
the
little,
guide closer to
We are
understand
little
where the
distally.
ostium is as well.
Yeah, you want to disengage a little more?
I think second wire is just confusing. It's not helpful.
So
Go a
should we
bit
take it out?
Closer to the
Is it all
ostium.
right? Let me show.
Yeah, it's too far out.
Yeah, you have to go more inside.
Yeah.
You can see the length of
have
left main
to-
that you have beyond your stent, right? So you know you have to be a little bit more distal based on your initial angio.
Yeah.
That's the importance of checking distal position in the epicaudal or caudal view compared to positioning checking in cranial views the ostium.
We have to come back a little, yeah.
No, sir. Distal will miss.
Huh?
Distal will miss.
I think once check cranially, position it correctly, then you check once caudally. If it's falling short, we can always change because left main.
Yeah.
So if you have sometimes problems like here in this situation, it's really not easy. Not
so is it
for
all right, sir?
everybody
Can you
it's
see?
difficult. What you could
We have
do,
come out and we
go
are
with a stand
1 millimeter
inside,
out of the.
Go closer with a guiding catheter to the osteum, and then going back on the way back, try to get the best position. And as you told, absolutely correct. Definitely check the projection in multiple projections.
I mean, I think the other wires may be hurting you. I'd pull the other wire back. I'd advance the stent distal into the left main, get your guide close, see where the true ostium is, and then back your guide out, I think. It might be more useful.
Yeah, we can see the ostium, sir, clearly.
You're too far back, because if you look at that calcium, so here you see that calcium, right? The calcium is at the distal part of the stent.
Back,
You are too much in the aorta.
Yes.
Definitely, a minimum 2.5 millimeter.
Even more, I would go further. Yeah, right there.
Now
it's closer.
Are you happy with this position? Let us see.
Cranial.
I would still go in 2 or 3 millimeters, because if I look at the calcium,
2 more inside, 2 millimeter more.
And then I would check cranie. I would go in 2 or 3 millimeters, do one angio here, and then check cranie.
Bhalo kore injection.
No, go more inside. Because nothing can happen, you know. It's you.
As they're doing it, can we move to Chennai for seeing them for 20 minutes and come back here? Is it done, Dr. Bhatia?
Okay, sir. It is all right.
It's okay.
No, it's okay, na?
It's okay.
It's okay, sir.
No, not sure. To be honest, I
think
I'm not 100% sure. I would suggest you are still too much inside the aorta.
Just check elevocranial view once again. Elevocranial.
Yes, LAO cranial, but not so much LAO.
If you see that calcium, the aortic marker should be about 2 millimeters proximal to that calcium. And right now you're in the mid portion, I think. So I agree. I would probably go in a little.
Give
bit,
a good injection.
Let's see this view.
Less LAO. It's too much. Less LAO, more cranial. Could you go a bit less LAO?
20.
Now you could have impression you are really too deep in the aorta.
Yeah.
Okay, check here. And
I
go with the guiding a bit closer to the left main, please.
I think your stent is out about 5 millimeters, so I think you need to go in.
Not so much, but probably 3
I think, sir, it's okay.
You please go inside little more, sir. Protruding too much into the aorta. It is protruding too much into the aorta.
This is a good view. This was the best view.
Half of the stent is inside, half is out of the aorta. Plus, go 2-3 mm more.
It's not moving.
No.
It didn't move.
Put both into the left main. So both stand in the guiding, and then on the way back we make measurements.
Okay, that moved. Now you're good. No, because you're near the calcium. No, now it's coming back again.
Okay, now again.
It came back. Yeah,
make a movie.
No, it didn't. It came
go
back.
inside again. It came back.
Came back, yeah.
The way it is jumping also suggests that it is coming back.
Yeah. I would also recommend to use EBU guiding. It will be more stable because This
Yes.
one
That's
is just
closer.
jumping.
Now take a shot there. Don't move anything, just take a shot. And I think this is close.
Yes.
That
this
is
is fine.
better.
This is fine.
This
Best.
is much better.
Yeah.
So I
Much
think it's
better.
okay, sir.
This
Yeah.
is better.
Yeah, much better, yeah.
Please go ahead.
So we are inflating the stent, sir.
Yes.
Yeah.
Okay, we are inflating.
There
Okay,
you see it,
खुले
yeah.
Press it, okay.
Move more back.
Little came back.
Still better.
Look at the missing head.
Okay,
Okay,
so
pressure's
what
down.
is
Falling.
what is your pressure now?
Blood pressure is coming
Pressure is
down, so
dropping,
come down with the
dropping.
balloon, I think. Yeah. It's in the
It has come down to 80, 90 now,
90.
85, 90, 100.
Okay. Okay, and now get the
So we
balloon
want
out.
to give another inflation.
Still flaring.
Yeah,
10.
Yeah.
देखिए. Yeah, we'll do it the flaring after this one. Yeah.
I think in many cases what I saw a few times, at least in 5 cases I saw,
Yes,
it was 4.0 stand in 5.5 left main, and
So we
then
are
the
flaring,
stand,
yeah.
because of
Yeah.
movements, dislocated. So, but here we have calcium. That's
Yeah,
good.
yeah, yeah.
Okay, that's calcium is stabilizing. But I would suggest to take care, take 5.0 non-compliant balloon and make
Yeah, take a 4
proper-
5 or at high pressure or
Yeah,
5.0.
yeah.
right
At,
minimum 5.0. I think
I
this
think we'll have to move to the next case. Maybe we can take one picture with the balloon down and take one and the balloon out.
Okay, yeah, we are, yeah. The picture.
that's much better.
So you have to
you
go
need
with a higher balloon.
non-compliant balloon, and
Yeah.
then everything
Yeah,
will be
yeah.
perfect.
देखिए.
So we're going to move to the next room, but the suggestions from Dr. Francis
Okay, sir. Okay,
is
thank
to
you very
take
much,
a
sir.
4.5 or 5.0 non-compliant at the ostium and hang it out into the aorta just to flare the ostium a bit more and give a better result. But that's a nice example of a tough osteo lesion. Thank you very much.
Thank you,
And
sir.
Thank you for joining us.
Thank you, Dr. Fennick. Thank
Okay.
you, all the
Thank
panelists.
you. All
Can
the
we
best.
move to Chennai?
We have taken, so this is the RFR wire, a pressure wire, and it shows that it is quite severe, and it is 0.71 and 0.69. Those are the two readings, because the borderline is 0.87 for RFR. In contrast to FFR, it is 0.8. So 0.71, 0.69, you can see it's 0.70 now. So I think we need to put a stent over there.
So you mean stand
So what is your-
distal to the old stand?
When you do a pullback, is that
Yeah,
where the
the
step up
LED,
is? If you do a pullback, is that where the step up
yeah.
is?
Do you want to see the pullback? Okay, sir, okay.
Are we live on the FFR, please? IFR?
Please put it.
Huh?
Yeah. RFR, yeah, please put it. We disconnected just
Oh, I
now
see.
to put the stent. So
No,
anyhow.
if you already did it,
Yeah.
that's okay.
No problem, sir. No problem, sir. Yeah. No problem, sir. Yeah, it's coming, sir. It's done. It's done, sir. Yeah, it's done. এটাকে এখানে রেখে দাও, হাতে রেখে দাও, হ্যাঁ, okay. Yeah, okay.
আরো
So
ভেতরে
show
ঢুকবে?
it, please. Show it, please.
আরেকটু ভেতরে
Dr.
যাও।
Fanek, we are showing. Please show. কি হলো?
The signal is not working. It's okay. Go ahead then. If
Okay.
Oh, there you go.
Now you got it.
Yeah. So it is 0.71, I think, 0.75,
and if you pull-
0.76, which are all significant, I think.
Right. If you pull back the wire a little
Yeah.
bit, does it jump
Would you
up?
like to pull back? Yeah.
Go into the
Yeah.
stand. And it's
Stand, yeah,
jump.
that's right.
It's better. Yeah.
So it is
then-
0.85 here.
Yeah.
So that
it-
indicates, we saw that it is, even after the left main, it is 1. So it is not significant much, it is 0.85. So we are going to stent. What is your opinion, sir, Dr. Fanek and Dr. Kodali?
think you need something like 3.5 or 3.0 12 millimeter stent and postulate. That's fine.
Yeah.
That's great.
Thank you, sir. And the left main we dilated with a 4.5 NC balloon at 20 ATM. And
can we maybe see left main?
And there is no. Yeah, this is the left main from subcostal view. Do you want to see the left main in any other view, sir?
Make the angio bigger.
Yeah. Please make the angio bigger. Yeah. Okay.
Maybe epicaudal.
Oh, Chennai?
Epicaudal.
You have taken a cranial view of LO?
Yeah. Show the cranial view, please. Show the cranial view.
Here we have some impression. Osteoalalia.
Osteal disease looks.
This one.
I think it's going to be a few step up. That's
This
the
one.
problem.
Okay, I think that left main osteal thing is done. Okay, there is some osteoalalia disease. I think is not important. Middle lady, you will treat it. Thanks for a good demonstration. We are supposed to go to switch to other lab for last few minutes. Thank you. Congratulations.
Okay.
Thank
you very much, sir. Please accept our respect and gratitude.
Thanks for
Dr.
doing
Fennick, Dr. Kahali, and all of you, sir, and all the audience. Thank you very, very much, sir. Thank you, sir. See you again.
Congratulations. Congratulations.
Thank you.